Our speaker today is Dr. Jess Yi. Dr. Yi is an assistant professor in the Department of Medicine. She completed her medical school at the University of Hawaii. I was questioning her wisdom of coming back to Ontario, but she convinced me that that was our right decision, which I agree with. And then she completed her internal medicine residency training at Mayo Clinic in Rochester, Minnesota. She came to McMaster in 2021, where she completed further training in internal medicine and thrombosis before joining us as an assistant professor on the academic staff here at the Juravinski Hospital in Hamilton Health Sciences. She has interest in education and is actively involved in undergrad medical education at the university and with the Thrombosis AFC Fellowship Program. And she is the Thrombosis Rotation Supervisor for the Hematology Fellowship. She's going to speak to us today about a topic that is we encounter quite a bit of in general medicine with a lot of interest from my end. I want to learn about anticoagulation and cirrhosis. So Jess is going to share that with us today. So without further ado, Dr. Yi, the floor is yours.
Thank you very much for the introduction. Today, I'll be presenting to you the topic of anticoagulation in cirrhosis. First, I would like to do a land acknowledgement. We're privileged to provide care on lands that Indigenous peoples have called home for thousands of years. I have no disclosures to make. For today's talk, the learning objectives are: 1, to review challenges of anticoagulation in cirrhosis. 2, to review current guidelines for anticoagulation and DOAC use in liver disease. This talk will be divided in 3 main sections. The first is to review the indication of atrial fibrillation and stroke prevention specifically. The second is in the context of venous thromboembolism, specifically DVT and PE. The third is portal-vein thrombosis. These are the abbreviations that will be covered in this talk. AFib, AF is atrial fibrillation. CP is Child-Pugh. You will see that throughout the talk. DOAC and low molecular weight heparin is pretty commonly used. PD is pharmacodynamic. PK is pharmacokinetic. PV is portal vein, and PVT is portal vein thrombosis. VKA is vitamin K antagonist, and in this talk, it is warfarin. I will start the talk with 3 cases, and there won't be any audience poll. I will do some pause at the end for you to think about which option you would do. At the end, we'll circle back to the answers. Case 1 is a 64-year-old man with alcohol liver disease, Child-Pugh B cirrhosis, new diagnosis of paroxysmal atrial fibrillation, has hypertension and heart failure, making CHATS to score of 2. He's no longer drinking. EGD 2 years ago showed mild portal hypertensive gastropathy, no varices, no prior bleeding events. He takes the following medications, including a beta blocker. He weighs 85 kilo. Here is the blood work. He does have moderate thrombocytopenia, renal functions appropriate, INR is 1.4, albumin is 32, bilirubin is 40. After risk-benefit discussion, he chose to proceed with anticoagulation for stroke prevention. What agent would you use? A, apixaban 5 mg twice a day. B, rivaroxaban 20 mg daily with food. C, the reduced dose of dabigatran of 110 mg twice a day. D, therapeutic low molecular weight heparin and bridge to warfarin. Okay. The next case is a 69-year-old woman with Child-Pugh C, viral cirrhosis, diagnosed with symptomatic, unprovoked left leg proximal DVT in the context of emergency room, has large volume ascites requiring regular paracentesis. EGD a year ago showed grade 2 esophageal varices that was banded, no prior variceal bleed. She takes the following medications, including a beta blocker. She weighs 57 kilo. Here is her blood work. She does have quite significant thrombocytopenia with a platelet count of 46, INR is 2.2, albumin is 20, bilirubin is elevated. The patient ended up being admitted to the hospital. Would you anticoagulate this patient for her proximal leg DVT? If yes, what would you choose or to start? A is apixaban 10 milligram twice a day for 7 days, followed by 5 milligram twice a day. So the usual kind of initiating loading apixaban regimen. B is dalteparin, 5,000 units twice a day injection, which is close to her therapeutic dose, just a bit under. C is dalteparin 7,500 units once a day, which would be an intermediate dose for this lady. D is no anticoagulation and to repeat ultrasound in 1 week time. Okay. The third and final case is a 62-year-old man with metabolic dysfunction associated steatotic liver disease and Child-Pugh B cirrhosis, who is incidentally found to have chronic partially occlusive thrombus in the right portal vein on an outpatient abdominal ultrasound done for HCC screening. There's no liver lesion found. He's otherwise well with no symptoms, has hypertension, dyslipidemia, and obesity, history of recurrent SBP. Here are the medications he's taking. He is currently being evaluated for liver transplant. Here is his blood work. Would you offer anticoagulation for this patient? If so, what agent would you use? A, apixaban 5 milligram twice a day. B, the reduced dose of dabigatran of 110 milligram twice a day. C, therapeutic low molecular weight heparin with bridge to warfarin. D, no anticoagulation, repeat ultrasound in 3 months. All right. So for this talk, liver disease, we commonly encounter them in both inpatient and outpatient setting. The most common etiologies are metabolic dysfunction, fatty liver, associated liver disease, alcohol, and viral etiologies. Historically, we think liver patients are auto-anticoagulated because of their abnormal coagulation labs, but in fact, these patients have a rebalanced hemostatic system that increases their risk of bleeding and thrombosis simultaneously, making them a very high-risk population. Child-Pugh scoring are often used to assess Child-Pugh scoring and MELD are the two most common scores used to assess the severity of liver dysfunction. Throughout this talk, I'll be referring to Child-Pugh scores in regards to DOAC usage. All DOACs undergo some form of hepatic metabolism to various degree. The landmark trials looking at DOAC versus warfarin for the indication of atrial fibrillation and also for venous thromboembolism have all excluded patients with active and significant liver disease. And this basis of exclusion is because of a DOAC named zimelagitran. It's hard to pronounce that DOAC, but it's from over a decade ago. The trials that involve this DOAC that you probably have not heard of reported hepatotoxicity, leading to eventually the discontinuation of this medication in 2006. The Child-Pugh score is used to assess the severity of hepatic dysfunction. We'll be talking quite a bit about Child-Pugh score here, so I want to put us here for a quick review. It uses both clinical and biochemical abnormalities to classify a liver disease as mild, moderate, or severe. Here's a table from UpToDate. It's also available on MDCalc. For Child-Pugh A, it's a score of 5 to 6. These patients have a median survival of 100%, so pretty good. They have usually compensated cirrhosis. Child-Pugh B is a score 7 to 9, and these patients have an 80% 1-year survival. They do have significant functional compromise. Child-Pugh C are often patients with decompensated cirrhosis, and they've developed complications of cirrhosis such as variceal bleed, ascites, SBP, hepatocellular carcinoma, or hepatorenal syndrome. And these patients have a pretty poor prognosis with a median survival of 45% at 1 year mark. And keep that very poor prognosis in mind. These Child-Pugh C patients have very high risk of dying. Like we briefly talked about earlier, there are many challenges in anticoagulation in cirrhosis. The biggest one is this rebalanced hemostatic system. Patients with liver disease are at increased risk both for bleeding and thrombosis. On one hand, the left side, you have thrombocytopenia, low levels of almost all coagulation factors, and fibrinogen that increase patients' risk of bleeding. Liver is responsible for producing a lot of these factors, and if liver function is impaired, hence the reduced level. On the other hand, which is the right side, you have elevated levels of von Willebrand factor, Adams TS13, and reduced level of natural anticoagulants in the body, leading to overall increased risk of thrombosis. As you can see, this is a very complex interplay involving so many factors. So in liver disease patient, low platelet count alone can be a poor indicator for bleeding. The other challenge for anticoagulation in this patient population is altered pharmacokinetic and pharmacodynamic effects. Low molecular weight heparin is historically the anticoagulant choice in this patient population. It does potentiate the effect of antithrombin to exert its anticoagulant effect. As you can imagine, reduced production of antithrombin and almost all of the coagulation factors can lead to altered anticoagulant effect. In addition to that, volume overload hepatorenal syndrome can alter drug absorption, distribution, and clearance. Next is warfarin. So it has a long track record of being used in chronic liver disease, but its metabolism actually heavily involves the hepatic system, more so than the DOAC. The reduced coagulation factors, plasma protein binding, hepatic impairment also affect warfarin's distribution and metabolism. And as all of you know, a lot of patients with advanced liver disease have baseline elevated INR, and that makes it challenging to use warfarin. We don't know what's the optimal INR target in that scenario. Last but not least, DOACs are becoming the preferred anticoagulant in this patient population because of many advantages and its convenience of use. But it's also affected and can have altered pharmacokinetic and pharmacodynamic effects in this patient population. All of the DOACs undergo some hepatic metabolism. Apixaban is actually the most hepatically metabolized DOAC, followed by rivaroxaban, and the least is dabigatran. The third main challenge of anticoagulation in cirrhosis is the very limited amount of data we have. They're primarily observational and often retrospective data. There's a large heterogeneity in the severity of liver disease of patients included in the studies. Some studies looked at liver disease as a very broad general term, while others looked at advanced liver disease or cirrhosis specifically. So for clarity, I'll be using the exact terms presented in the original study to make it clear. Studies also included few patients with advanced liver disease, and that's the highest risk patient population. We often don't know what the most optimal anticoagulant strategy is. So there's a large practice variability as a result of all these challenges and limitations. Now I will discuss the section 1 of this talk, which is atrial fibrillation. It's one of the most common indications for anticoagulation in liver disease. There is significant burden of atrial fibrillation in liver disease. It's quoted to be about 5% in terms of prevalence, and this prevalence increases with disease severity, as you can see here. The increased risk of atrial fibrillation in cirrhotic patients is due to a complex interplay of many shared risk factors. A study showed that atrial fibrillation was associated with about a 1.4-fold increase in mortality in cirrhotic patients. This table summarizes the results of mostly retrospective observational data, anticoagulation versus no anticoagulation in atrial fibrillation in cirrhosis. The first one is a meta-analysis, followed by 3 more recent cohort studies assessing the risks and benefits of, again, anticoagulating versus not anticoagulating in the context of AFib and cirrhosis. Some of the studies actually liver disease, so a combination of both. Overall, anticoagulation was associated with significant reduction in risk of stroke and mortality, and no signal for increased bleeding risk. This sounds too good to be true, does it? At least I think so. Keep in mind that these are observational studies which are at risk of bias. It is likely those who are at higher risk for ischemic stroke, embolic events, and lower risk of bleeding were the patients that clinicians were anticoagulating. The studies included patients mostly with lower Child-Pugh or MELD scores, except for the final study that looked at exclusively Child-Pugh C patients. However, the last study was only published as an abstract form. This first study that we're going to look at is a post-hoc analysis of ENGAGE AF TIMI 48, which was initially published in New England Journal in 2013. It's one of the big RCT trial, looking at the efficacy and safety of edoxaban versus warfarin in atrial fibrillation patients. And the original study had 21,000 patients. 5% of that patient population had history of liver disease and or liver enzymes that's 2 times or higher of upper limit of normal. This original trial did exclude patients with active liver disease or persistently elevated liver enzymes. But these patients that the 5%, they did not quite meet the exclusion criteria of the original trial. The post-hoc analysis was on this subgroup of patients. The study didn't really specify the Child-Pugh score of this 5% of patients, but you can think of them as at most Child-Pugh A. The follow-up is 2.8 years. Primary efficacy endpoints is stroke or systemic embolic events, and the primary safety endpoint is major bleeding. Among the patients with liver disease, compared to with those without, there was no significant difference in the adjusted risk of stroke or systemic embolic events, suggesting perhaps a similar treatment effect between edoxaban and warfarin. The adjusted risk for major bleeding was significantly higher among patients with a liver disease than those without, so about 1.4-fold higher. Now, looking at specifically edoxaban versus warfarin, the annualized rate of stroke and systemic embolism and the annualized rate of major bleeding, there's no significant difference between the groups. So it appears that history of liver disease did not alter the relative efficacy and safety of edoxaban compared to with warfarin. The authors also looked at hepatic adverse events. In general, they were quite rare, and they were similar between the groups. This study had the limitation of limited power because of relatively small number of events in the liver disease subgroup. Also, in my opinion, the history of liver disease was defined quite loosely and subjectively by site investigators without formal evaluation, and there could be some misclassification. Lastly, there's no representation of any patients with active or more advanced liver disease, and mostly they were patients with a mild liver condition. The second study is actually an RCT, but a very small RCT. It compared dabigatran, the reduced dose of 110 milligram BID, with warfarin for stroke prevention in AFib patients with cirrhosis. So in this study, it's cirrhotic patients. N is only 56. Follow-up is very short at 3 months. The study included Child-Pugh A and Child-Pugh B patients, again, no Child-Pugh C. There were no thromboembolic event or fatal bleeding in either group. The authors chose the lower dose dabigatran because prior literature showing that the reduced dose is effective and safe for patients who do have additional bleeding risk factor, and usually cirrhosis would constitute that bleeding risk factor. Looking at the results, this very small study showed that patients treated with warfarin had a significantly higher overall bleeding rate than patients treated with dabigatran. This difference is driven mostly by minor bleeding, though. There was one major bleeding in the warfarin group, and it was gross hematuria, but no major bleeding in the dabigatran group. The authors also found that the two factors, prior history of bleeding and also renal impairment, were associated with increased risk of bleeding. There are several important considerations and limitations from this small RCT. It's a very small study with a very short follow-up, and that excluded advanced renal impairment. I want to point out the author did chose the lower dose of dabigatran, which I think is appropriate because of the risk of bleeding. The baseline creatinine was higher in the warfarin group, and the timing therapeutic range for warfarin was not reported despite being an RCT trial. The last 3 points could have potentially contributed to biasing the results of lower bleeding with dabigatran. I will now share some clinical outcome data comparing DOAC, both individually and as a class, versus warfarin in patients with AFib and chronic liver disease. So this study by Lowell and colleagues was a large retrospective cohort study published in Circulation in 2023. It included patients with chronic liver disease initiating DOAC versus warfarin for atrial fibrillation from the period of 2011 to 2017. The study had 10,000 patients. 43 were prescribed warfarin, 27 apixaban, and 22% rivaroxaban. The other DOACs were used in very small quantity. Majority of patients were prescribed standard dose. Primary outcomes were hospitalization for ischemic stroke or systemic embolism and hospitalization for major bleeding. This study was also the first one to perform a head-to-head retrospective comparison of DOAC. It looked at rivaroxaban versus apixaban specifically, and we'll review that in a little bit. The median CHA2DS2-VASc was 4. In this study, the authors found that compared with warfarin, patients treated with DOAC as a class had a 36% lower risk for ischemic stroke systemic embolism, looking at the inverse probability of treated weighing hazards in the last column. A 31% lower risk for major bleeding, a 24% lower risk for all-cause death, and a 27% lower risk for major bleeding. As I mentioned earlier, this was the first study to look at a head-to-head retrospective comparison between DOACs. The authors compared rivaroxaban versus apixaban specifically. These are the two most commonly prescribed DOAC. They found that compared with apixaban, patients treated with rivaroxaban had a almost 1.6 times fold higher risk of major bleeding and a 2.1 fold higher risk of major GI bleeding specifically. This differential bleeding risk between rivaroxaban and apixaban have been reported in many other real-world studies, although we don't really know why and what mechanism. It has been hypothesized perhaps the higher peak levels associated with once-a-day rivaroxaban dosing may partly explain its higher risk of bleeding compared to apixaban, which is dosed as twice a day. This large observational study, again, is subjective to unmeasured confounding factors. The authors did not really report Child-Pugh scores. We don't really know the timing therapeutic range for warfarin and the INR control. The fourth and final study that I will talk about in this section is another observational study that consisted of two population-based cohorts, one in the UK and the second one in Quebec. It looked at patients with liver disease initiating DOAC versus warfarin for atrial fibrillation from 2011 to 2020. It again compares DOAC versus warfarin and also apixaban versus rivaroxaban. This is a retrospective comparison. The study had almost 12,000 of patients, and 2,600 patients had cirrhosis. Now we can see 39 patients patients were prescribed with apixaban, followed by warfarin, and followed by rivaroxaban. The other DOACs were used in, again, small quantity. This cohort study suggested that DOAC are as effective as warfarin and perhaps slightly safer in terms of major bleeding risk. This risk-benefit balance was not altered when the authors looked at the subgroup of patients with cirrhosis. When the authors looked at apixaban versus rivaroxaban specifically, apixaban was effective and safer than rivaroxaban. As you can see here, apixaban was associated with a 20% lower risk for major bleeding. However, the safety benefit of apixaban over rivaroxaban was not appreciated when the authors looked at the patients who have cirrhosis. A potential explanation could involve apixaban having a higher hepatic elimination compared to rivaroxaban. So perhaps in patients with more severe liver dysfunction, this pharmacokinetic difference could lead to stronger accumulation and hence toxicity in apixaban. This table summarizes the key observational studies assessing the risks and benefits of DOAC versus warfarin for atrial fibrillation patients with liver disease. We looked at Lawal and colleagues and Dorals and colleagues. The Menicelli from 2023 is a meta-analysis, while the other 4 are cohort studies. Overall, these observational evidence suggests DOAC are similarly or more effective than warfarin in preventing stroke and death in patients with atrial fibrillation and liver disease. And DOAC are associated with a lower risk of major bleeding and intracranial hemorrhage when compared to warfarin. All studies, except for the last one, presumably included patients with less severe liver disease. Although this information was not specifically reported or available in many studies. As we all know, observational data may have been affected by important confounding factors. For example, we know from studies that patients from a higher socioeconomic class have been shown to have to be strongly associated both with lower risk of adverse clinical outcomes and also a higher probability of receiving DOAC than warfarin. Dorals and colleagues study from 2024, they did adjust for socioeconomic status while the other studies did not. So what does the guidelines say in this area? The American Gastroenterological Association from the guideline from 2021 suggests anticoagulation over no anticoagulation for the indication of atrial fibrillation in cirrhosis patients. It did make a statement that those with Child-Pugh C cirrhosis and or low CHA2DS2-VASc score could very reasonably choose no anticoagulation. The AHA-ACC guideline from 2023 states that all DOACs can be used in their standard dose in Child-Pugh A. In Child-Pugh B, you can use all the DOACs with caution, but it recommends you avoiding rivaroxaban. For Child-Pugh C, avoid all DOACs. The International Society on Thrombosis and Hemostasis, or ISTH, from 2024, recommends all DOACs in their standard dose in Child-Pugh A and B. Child-Pugh C, there's no inadequate evidence to make a recommendation. Lastly, case-by-case consideration of left atrial appendage occlusion can be done, and this is outside of the scope of this talk. So essentially, all guidelines suggest avoiding DOAC in Child-Pugh C cirrhosis. In the context of atrial fibrillation, stroke prevention, patients' preference and values really matter, and it should be a shared decision-making process, acknowledging our limited literature in this patient population. Now I'll move on to the second section of this presentation, which is on anticoagulation for DVT and PE in patients with liver disease. Patients with cirrhosis are about twice more likely to have a VT event when compared to those without liver disease. After a VT event, patients with cirrhosis have a higher risk of dying. And studies shown that patients with liver disease are less likely to receive anticoagulant treatment for VT compared to those without liver disease. And it's a striking 37% versus 77%. Again, there's minimal data to guide treatment decisions here because the large trials looking at DOAC versus warfarin in patients with VTE also excluded patients with cirrhosis or active or clinically significant liver disease. Available observational data seems to suggest that DOACs are as effective as warfarin with respect to prevention of recurrent VTE in this patient population. Lawal and colleagues also did a study in this area and published in 2024, a large retrospective U.S. Cohort study from the time frame of 2011 to 2017, looking at patients with chronic liver disease initiating DOAC or warfarin for acute VTE indication. The study had 8,000 patients. Majority were prescribed warfarin. 37% were prescribed DOAC. Again, apixaban, rivaroxaban were the most commonly prescribed here. 29% of patients had cirrhosis. Child-Pugh score was not reported. Primary outcome is a composite of hospitalization for recurrent VTE and hospitalization for major bleed. In this study, the authors found that DOAC was associated with a 28% lower risk for the composite outcome of hospitalization for recurrent VTE or major bleeding. This risk lowering is mostly driven by reduction in major bleeding, as you can see here. The reduction in primary outcome was also seen in cirrhosis and decompensated cirrhosis subgroups. The observed differences favoring DOAC were again greater with apixaban than with rivaroxaban. What about thrombocytopenia in patients with cirrhosis? Evidence regarding this outcomes of VTE treatment in patients with thrombocytopenia mostly come from observational studies in cancer patients. It's a common scenario. Patients who have cancer have thrombocytopenia and then also DVT or PE. In cancer patients, you've probably seen this before, we often use this modified low molecular weight heparin regimen for patients with very severe thrombocytopenia. Essentially, in general terms, if the platelet count is 50 or greater, we find that full dose anticoagulation is generally acceptable. For a platelet count of 25 to 50, you can use prophylactic dose or half therapeutic dose of low molecular weight heparin. For patients with a platelet count of less than 25, we generally avoid anticoagulation because the bleeding risk we think is too high. Like we talked about earlier at the beginning of this presentation, platelet count is overall a poor predictor of bleeding risk in this patient because of the counteracting mechanisms. There's very limited data from patients with liver disease and thrombocytopenia to inform practice. Nevertheless, in real world, we do apply similar set of rules we use in cancer patients to our liver patients when it comes to thrombocytopenia. The ISTH guidance and guidelines in this area and for this indication of acute DVT or PE cirrhosis recommend anticoagulation over no anticoagulation in patients with Child-Pugh A or B with either of these anticoagulants, unless there's any active bleeding concerns or other contraindications. In Child-Pugh C, unless bleeding, it also recommends anticoagulating with low molecular weight heparin alone, or as a bridge to warfarin eventually if the patient has a normal baseline INR. Of course, you have to take into the patient's preference and values into consideration. For patients with very severe thrombocytopenia and a platelet count less than 50, the decisions are highly individualized, taking into account many factors. This is a very high risk and high morbidity mortality situation. The third and final section is portal vein thrombosis and cirrhosis. I just want to talk a little bit about the portal vein anatomy. It carries blood from the GI tract and spleen to the liver. The main portal vein is formed by the confluence of superior mesenteric vein and the splenic vein. Upon entering the liver, it then divides into the left portal vein and the right portal vein. Portal vein thrombosis is quite uncommon in the general population, but it's quite a common occurrence in patients with chronic liver disease, and the incidence and prevalence increase as the severity of the liver disease increases. The prevalence about 10% in those with compensated cirrhosis, 17% in patients with Child-Pugh B and C cirrhosis, and up to 26% in patients with who are candidates for liver transplantation. It's frequently chronic, asymptomatic, and an incidental finding on imaging. Age of thrombus can be hard to tell based on traditional imaging techniques, but the definition we agree upon is recent portal vein thrombus, often considered those that occurred presumably less than 6 months ago. Chronic is if it's over 6 months ago. Fortunately, ischemic bowel is quite rare in portal vein thrombus in cirrhotic patients because of the presence of collaterals, usually. Chronic portal vein thrombus increases the risk of variceal bleed, variceal recurrence after treatment, and also ascites. In patients who are potential liver transplantation candidates, it is important to maintain a patent portal vein system. Because of this transplantation potential, portal vein thrombus can complicate surgery, impede anastomosis, and increase post-transplant mortality. Guerrero and colleagues did a individual patient data meta-analysis of 500 patients with cirrhosis and portal vein thrombus from 5 cohort studies, and these are patients with non-malignant portal vein thrombus. 41% of patients received anticoagulation versus 59% patients did not receive anticoagulation. The primary outcome was all-cause mortality, and the secondary outcomes were portal vein recanalization and bleeding events. The 5 cohort studies were published between anywhere from 2016 to 2019. The anticoagulants used at that time were low molecular weight heparin and/or warfarin. The studies did not include patients treated with DOAC. The study also didn't report on the acuity of portal vein thrombus, which can be hard to tell in a lot of scenarios. This meta-analysis of cohort studies observed that anticoagulation appears to be associated with a 41% lower risk of death independently of the portal vein thrombus severity and recanalization. It's also associated with increased rate of recanalization rate, about 3.5-fold. Anticoagulation significantly increased the non-portal hypertension-related bleeding events. So you helped with recanalization rate, but at the expense of bleeding event, the non-portal hypertension-related bleeding specifically. These 5 cohort studies were quite heterogeneous in terms of their portal vein thrombus severity and the anticoagulation regimen they used. And with the observational data, we again cannot exclude the residual confounding. There's limited evidence of DOAC use in portal vein thrombus in general, and more specifically liver disease. Cole and colleagues did this study, meta-analysis, looking at 11 studies, 10 observational and 1 RCT that compared DOAC versus warfarin in non-malignant chronic portal vein thrombus in cirrhotic patients. I want to point out that, sadly, the only RCT here has since been retracted due to methodologic concerns. This meta-analysis had about 500 patients, mostly Child-Pugh A and B patients with cirrhosis. Compared with VKA, DOACs were associated with higher rates of portal vein recanalization and a lower risk of portal vein progression. Both groups had similar rate of major bleeding, variceal bleeding, and death. So the limited data from small cohort studies and meta-analysis seem to suggest that DOAC is a reasonable alternative for the treatment of portal vein thrombus in cirrhotic patients with Child-Pugh A and B disease severity. So what does the guideline say? Here I included 3 guidelines, the AGA, ISTH, and Baveno 7. All guidelines agree that anticoagulation, and they recommend anticoagulation for recent portal vein thrombus that involves the main portal vein, or if there's evidence of progression of portal vein thrombus on short-term imaging without anticoagulation, or portal vein thrombus in potential liver transplant candidates. The guidelines have conflicting guidance on in terms of asymptomatic or chronic portal vein thrombus. For example, AGA suggests not to anticoagulate if chronic portal vein thrombus with complete occlusion and collateralization. At HHS, our practice most aligned with the ISTH guideline, which was published by Stephanie Carlin in 2024. We anticoagulate symptomatic portal vein thrombus, asymptomatic but progressing portal vein thrombus, and those who are liver transplant candidates or potential liver transplant candidates. For those who are asymptomatic, even if they're not liver transplant candidates, we assess them case by case basis, and unless they have bleeding issues or other contraindications, we offer anticoagulation. So what are the take-home messages by sections? So overall, observational data, low quality, but with what we have, guidelines suggest anticoagulation with DOAC in Child-Pugh A and Child-Pugh B cirrhosis patients with atrial fibrillation, but avoid DOAC in Child-Pugh C. The limited data seems to suggest that when compared to warfarin, DOACs are similarly or more effective in preventing stroke and death in patients with AFib and liver disease. It's also associated with a lower risk of major bleeding and intracranial hemorrhage. Apixaban appears to be safer than rivaroxaban. For VTE and liver disease, here are the take-home messages. So available observational data suggests DOACs are effective, as effective as warfarin in preventing recurrent VTE in chronic liver disease. Again, they are suitable for Child-Pugh A and B. And in Child-Pugh C, which is a very high-risk situation, you want to be using low molecular weight heparin cautiously, at least initially, and consider bridging to warfarin if the patients have normal baseline INR and it's in line with their preference and values. For the final section, portal vein thrombus, so what are the take-home messages? The limited data from, again, small cohort studies and meta-analyses suggest that DOACs is a reasonable alternative for treating portal vein thrombus in Child-Pugh A and B cirrhosis. Anticoagulation in portal vein thrombus in cirrhotic patients appears to reduce all-cause mortality independently of thrombosis severity and recanalization. Again, this is based on observational data. All guidelines recommend anticoagulation for recent portal vein thrombus involving the main portal vein, or progressive portal vein thrombus, or portal vein thrombus in potential liver transplant candidates. Now we're going to go back to the cases. The first case is a 64-year-old man with alcohol liver disease, Child-Pugh B cirrhosis, who is diagnosed with paroxysmal AFib. CHADS2 is 2, not drinking anymore. EGD 2 years ago showed mild portal hypertensive gastropathy, no varices, no prior bleeding events, weighs 85 kilo. Blood work is pretty appropriate for anticoagulation. The patient also would like to proceed with anticoagulation. In this case, I would choose apixaban 5 milligram twice a day, which is the standard dose. I wouldn't choose rivaroxaban because based on what we have from the observational data, apixaban seems to be safer than rivaroxaban. I wouldn't pick the dabigatran because most of the studies we talked about, very few patients were on the dabigatran, even though it's the least hepatically cleared drug. There's pharmacokinetic studies from in vitro, in vivo data suggesting maybe it's associated with excessive anticoagulant effect in patients with liver disease. And the last choice, I think, is just cumbersome with a subcutaneous injection or the warfarin monitoring. So most of the time, patients would not want to go with that option. The second case is a 69-year-old woman with Child-Pugh C, hepatitis B related cirrhosis, has proximal DVT, and EGD from a year ago showed grade 2 esophageal varices that were banded. Luckily, fortunately, no history of variceal bleed. On beta blocker, weighs 57 kilo, has pretty significant thrombocytopenia of a platelet count of 46. Patient was admitted. In terms of these options, I would pick C, dalteparin 7,500 units subcutaneous injection daily, which is an intermediate dose for the patient. I can see myself doing B as well, dalteparin 5,000 units twice a day, which is a bit less than the therapeutic dose. Because the patient will be monitored inpatient, so you can reassess anticoagulation on a daily basis. Because of the Child-Pugh C, the risk of bleeding, and the patient will be in the hospital being monitored, I think C, in my opinion, would be the safest choice. Because it's Child-Pugh C, we wouldn't use DOAC, and because it's proximal DVT and no immediate bleeding concern, I think offering anticoagulation would be preferred over not anticoagulating. The last case is a 62-year-old man with Child-Pugh B cirrhosis, incidental chronic partially occlusive thrombus in the right portal vein, and an outpatient ultrasound. Patient's well, no symptoms, is being evaluated for liver transplant. Blood work is pretty acceptable for anticoagulation. In this scenario, I would pick apixaban 5 milligram twice a day. For this patient, I wouldn't pick the bigatran again, just because out of the studies we have, very few patients were prescribed a bigatran. I would favor anticoagulation over no anticoagulation because of the potential mortality benefit, again, based on observational data, so take that with a grain of salt. Therapeutic low molecular weight heparin, nothing wrong with that. It's just cumbersome. So a lot of patients would not prefer to have daily injections or warfarin monitoring. If there is any risk factor in this patient that make you more worried about bleeding, I think a low dose of apixaban 2.5 milligram twice a day would also be reasonable. Lastly, I want to acknowledge and thank Stephanie Carlin for her tremendous contribution to this presentation. She's the author for the ISTH guidance and guidelines published in 2024 in this topic, and her expertise in the field was really appreciated. Secondly, I want to really thank and acknowledge my mentor, Dr. Lori-Ann Linkins, for her very helpful feedbacks. It was my pleasure to present this topic to you. I hope I answered some of your questions and made you less confused, or perhaps more confused. Thank you for your attention and time. I'm happy to take any questions now.
Thank you so much, Dr. Yi, for this review of literature and a very complex topic. There's no doubt about that, as we've highlighted earlier. And absolutely, thanks to Dr. Linkins and Stephanie Carlin. Both are in the audience, so they may support you in answering questions as well, so thanks to everyone. All right, if you have a question, please put it in the Q&A. You can put comments in the chat if you want, or raise your hand so I can bring you in. Dr. Holbrook, I'm just gonna unmute you in a second. Allow Mike. Go ahead, Dr. Holbrook.
Thanks very much. Yeah, that was a very nice presentation. I agree with Lori-Ann and Jim. Just a quick comment, Justin, a question for you. In the community of clinical pharmacology that looks at pharmacokinetics very intensively, I think we're less concerned about liver disease than non-clinical pharmacologists. So we rely very much on the actual evidence of outcomes, not so much on the pharmacokinetics. So in that regard, I think as time has played out, DOACs have proved to be even safer than we originally thought. And I predict even in severe, like your liver has to be almost destroyed to really affect kinetics in a way that's going to affect clinical outcomes. And my question is just around clarification in the atrial fibrillation. I thought probably the best summary of your guideline data was ISTH again, which basically just said the evidence is inconclusive. In other words, a lack of evidence rather than a lack of evidence against DOACs. Could you just go over that again briefly? In other words, for Child-Pugh C, it was more that we don't really have any good evidence in that. We don't have good evidence in any area because it's not dominated by randomized trials, but there's just really insufficient evidence. Wasn't that the conclusion?
Yes, absolutely right. Yeah. So even AGA in Child-Pugh C, it didn't say not to anticoagulate. I think they were saying reasonably not to anticoagulate. The ISTH definitely. I think Child-Pugh C just overall so little data in this advanced disease group that they concluded there's really inadequate evidence to make a suggestion for or against DOAC or not. So you're right. Yeah.
Thank you, Jess. And all right, we'll bring in Vinay. Go ahead. Oops, no.
Yeah, can you hear me?
Oh, you're good. Yeah, go ahead.
Great, thank you. Jess, that was a great presentation. Thanks for delivering it. One of the things that we sometimes run into is patients who are actually on the transplant list, like they're candidates for transplant and they're on the list. And there's this concern that if we use an agent that's not easily reversible, that if they get a call for surgery, that they won't be able to get their transplant. And it's not a common thing, but it does happen. Sometimes in those cases, I've been tempted to use dabigatran since we do have a reversal agent easily available, or warfarin if the INR isn't terrible at baseline. And I'm just and I don't know the sort of right answer to this, but I was wondering if what your thoughts are on that question.
Yeah, thank you for sharing your experience. I have actually had a lot of experience anticoagulating patients who are on the liver transplant list. Out of the few I can think of, I think they were on low molecular weight heparin, but that was also because their platelet count was quite low. I think using dabigatran and warfarin in this case are totally reasonable. I think based on the guideline, warfarin is one of the options that we can use, and what you suggested makes sense. And I think in terms of dabigatran, we don't really know if dabigatran is not as good as the other DOACs for sure. I think it was just because a lot of the observational limited data we have, like the dabigatran prescription was like less than 10%. So I guess people's overall comfort level is more towards the ones that were commonly prescribed. But like what you pointed out, if there's a pretty valid and strong argument for the dabigatran, I think that's totally reasonable. Yeah, but thank you for sharing your experience in that area.
And I see Stephanie has left a comment there that typically prior to transplant, Toronto General wants patients switch to warfarin or dabi. So that kind of fits with what you're saying. Jess, if I could just one other quick question is, do you have an INR cutoff that above which you would say, I definitely don't want to, like a baseline INR cutoff above which I definitely don't want to use warfarin?
For me, in my mind, I'm thinking 1.5, but I'm also happy to hear kind of what you would do. Do you have a cutoff?
No, but I'm going to go with 1.5 because you said it. You're the expert. Thank you, Jess.
I randomly picked that number. It's in the middle from 1 to 2. If it's above that, I'm just getting less comfortable. Like, is that Is that going to be effective for the patient? But again, maybe nobody really knows.
Amazing. I can see how this topic is getting more complex when we have all these thrombosis experts, which we are privy to have in our institution, and yet we're debating a little bit, which is great. The evidence is not fantastic. However, you have put it in a really fantastic way and very simple way for us to digest, Jess. So thank you.
Thank you very much.
Dr. Lincoln says a comment that the problem is that INR is not reflective of the degree of coagulopathy. Yeah, and lots of comments on how fantastic this presentation been. I'm gonna read. I like Jim to have this comments. Tight presentation, Jess. So, and I agree with that. Just I'm gonna ask a question about such like complex topic, limited, strong evidence, I should say, not limited evidence. There's a lot of evidence, but it's not high level of evidence. How much of, shared decision making with the patient you practice in situations like this one? And would you pull such a complex presentation to the patient to make a decision with them on which would be your choice if there's a not a clear one in the evidence that you've shared with us?
That's a great question. I actually rely on patient so much more than I rely on the very limited data. I think a lot of thrombosis cases are very challenging involving liver patients. They're high risk of bleeding, high risk of clotting. A lot of times I'm sitting there, I'm like, I don't know, either one makes me uncomfortable. So I tell the patient that. I say, you have a clot, it's a risk of bleeding, and these are the options. And I share my worries, fears with them. And usually they can tell me, they will say, I prefer X or Y, or they say, you're the doc, you make the recommendation, I will do whatever you recommend. So that's the third option. And in that case, I would ultimately commit to a plan. So I really enjoy that shared decision-making process with a patient, because reality is a lot of times I am not sure what the best approach is. And I want the patient to understand that and to kind of guide me in kind of what they value. Is it they're more afraid of bleeding, or they're like, I really don't want to have a stroke? And that is very helpful for me to know.
Excellent. Thank you for sharing your insight and experience. There's a question from Dr. Hunt on any comments on DVT prophylaxis for admitted cirrhosis patients.
Yes, so definitely DVT prophylaxis, unless they're bleeding, or if their platelet count is less than 30. I think it's pretty agreed that they should have DVT prophylaxis. Yeah.
I like how your voice went down when you said less than 30. So,
I know.
30. That requires a lot of courage among GIMers like myself, to wait till platelets less than 30. And I understand the evidence, but yeah, okay, less than 30. Good. Fantastic. Or bleeding. Yeah, absolutely. If they're bleeding, more from one perspective. Okay, fantastic. Excellent, Jess. We are at time. This has been an outstanding. And the second, I think it's important to mention transmission. So I should still get VT prophylaxis on less bleeding. Okay, thanks, Stephanie, for the comments. So it's just there are hypercoagulable that benefits from DVT prophylaxis. Thank you so much, Dr. Yi, again. This was an outstanding presentation. Very well done. Excellent review of the current literature and your experience, and fantastic discussion with lots of input from expert colleagues. So thank you very much, everyone. This is truly the last Hamilton Health Sciences Grand Rounds for the academic year. Next week, still we have one from our colleagues at St. Joe's, and that would be, then we'll go into the summer hiatus, and we'll see you then in September. So next week, St. Joe's Grand Rounds, and following that, summer vacation. So from me, I wish everyone fantastic summer. It's going to be a bit hot this summer, so stay healthy and hydrated. Enjoy the rest of your day. Thank you, everyone.
Thank you. Take
Thanks,
care.
Jess. Take care.
Bye.
Bye.